Welcome to Inside Aesthetics, the world's leading podcast for injectors and cosmetic businesses. I'm Dr. Jake Sloan, an aesthetic doctor based in Sydney, and I'm joined by my co-host and good friend David Segal, an entrepreneur and an aesthetic business mentor. Each episode of IA showcases unfiltered conversations with guests from around the world. In a sometimes disjointed industry, IA aims to help educate and connect our global community to raise the bar for both our businesses and our patients.
To further support and educate our listeners, we offer a range of additional resources under our IA Patreon subscription service. This caters for injectors and business owners of all levels and includes interactive live Zoom sessions, webinars, hints and tip videos, private chat groups, and exciting future content to come. To subscribe to IA Patreon, head to www.insideaesthetics.com/Patreon or click the link in our podcast description. You should seek medical advice before undergoing any treatment or procedure, and these podcasts do not replace a professional and bespoke consultation.
We're back again in the studio with, shall we call her Jubilant Julie? I don't know. We had so few names in our last episode with Julie. But welcome back, Julie. Nice to see you again. Today, we are going to do one of our Disasters and Solutions podcasts, which I think we planned originally to do more, but you know, some of these disasters are less frequent.
Yeah, and not everyone's willing to talk about them.
Exactly, that's half the problem. Not everyone's willing to talk. So we've got a master of disaster in our studio today, in a good way, because you handled the disaster. And it wasn't, you weren't in the injector, but we're going to get into all of that. But this is chapter 3 of Disasters and Solutions. And what we really tried to do with these ones, if it wasn't clear, is we're not trying to judge injectors. We all have complications. I've had occlusions, Julie's had occlusions, David's managed occlusions from injectors who would work for him. They are, to some extent, unavoidable. But if we can learn some, I don't know, golden nuggets or pearls of wisdom from what Julie has to tell us, maybe we can mitigate that problem and reduce the probability. Yeah. So that's the point of these ones. So, yeah.
Yeah, well, we've got to share to learn.
Got to share to learn. So, that's Julie, right. Welcome again. How's your week been? Because it's been a few weeks since we've spoken to you.
Brilliant.
Yep. Okay, perfect.
It's been busy, but everything's great.
Excellent. Perfect. So this story was around on your Instagram. Time is flying. I think about a month or 6 weeks ago. I can't remember exactly when it was doing the rounds, but everyone was...
June 14th.
Oh, Jesus Christ. Okay, time's really flying.
You also remember the dates of your own disasters.
Yeah, okay, fair.
It's funny.
But to give the listeners context who haven't come across it, there was an injector in your clinic treating a lovely patient. I think it was chin filler, and she suffered an interesting occlusion. So why don't you tell us more just about the background of, what happened that day, who was the patient, what was the plan, what was the backstory?
So the backstory is that one of our newer injectors on our team, I've been injecting for about a year. And on the last podcast, we talked about somebody who is one of those people that pick it up, that's passionate, to pick it up fast. She's one of those injectors, right? She's a sponge and she's talented. So she, I taught her how to inject. She's been to several of my workshops, really wonderful injector. So she decided to record the chin injection and show me when I got back, because I've seen her do chins before. She did great. So she recorded it. She had somebody record it. And also she recorded an ultrasound of the chin before as well. So she had 2 recordings before it happened. And, it's kind of cool, because how many disasters do you have that you can actually look at the video and see it happen? And, I was in Japan visiting my granddaughter, and of course, 16 hours ahead of time. So when it happened, I was asleep. It happened, in the early mornings of in Redding, California, and in Japan, it was the middle of the night. So when I woke up, I had several messages from my office team saying, please call us right away as soon as you wake up. And I called them. And they said, we got a vascular adverse event that's a bad one. And I was like, oh no. And they sent me pictures, and this poor patient stuck out her tongue, and half of it was white, half of it was pink.
Before you go into the meat of it, what was the purpose of the injection? Why was even the patient there? How many mils were used? What was the expectation of the treatment?
So the patient has seen us before with previous lip fillers, and this injector did a really good job with her lips, and she came in and got a consultation, and her chin was a little bit wide, a little bit masculine. So they were just going to put some in the center of her chin to feminize it and bring it down a little bit, feminize the chin and kind of frame her lips a little better. So, the assessment was great. The patient really, would have looked good. I didn't see that because by the time I saw her, she was Hyalonix, but I'm sure it looked good, except for that half of her tongue was white, right? So it was just a routine. Oh, I love what you did with my lips. Let's do my chin next. And she did have a history of a little mini facelift, but other than that, no surgeries. Non-smoker, which is helpful.
How old was the patient?
30s, in her 30s.
And presumably she'd had her lips done already. So she was consented for, filler and presumably complications, etc. So how do you guys run it in your clinic? Is it a paper form? Is it digital form? Do you do it every time you do a new filler? Like, I think this varies state to state and country to country, and to be honest, practitioner by practitioner. So how do you guys run the consenting?
So we have them sign 2 consents. So we talk about all the things that could happen, on-label, off-label, what fillers cannot be reversed, and we're just straight up with them, tell them it's rare. But that, I'm just so straight up. I'll say, hey, look, in my career, I've caused these types of adverse events 5 times in 25 years of injecting. I've seen it 5 times with my own hands. And I've seen hundreds, maybe even more than hundreds, but throughout my career with other injectors. So it happens, but it is fairly rare. I think we need to be real straight with everybody.
Yeah. Do you find that newer injectors, either employed by you or those who you train, they struggle with that consent process because they're worried of scaring people off? And then, it's obviously not good, but they sort of dance around the subject. Have you found that?
Yeah, I do. In fact, I assist the nurses in my office, and I'll assist them, and I'll say, but we haven't talked about adverse events yet, like a nudge them, because it should be something that never gets forgotten about. And I think maybe they're just nervous because I'm sitting right in the room with them, but I don't ever want that to be forgotten.
And is that something that you go over every single time you do a treatment with the patient, even if they've been with you before?
Yeah.
Okay.
Yeah. If they already know, I'll go, you know what this is, you know how it works. We've done this before, but do you have any questions about any adverse events that we've just discussed before?
Yeah. Okay.
Because maybe they learned from the time they saw me, they learned something else, and they're curious about it, or maybe they heard misinformation, and it's an opportunity for us to check their knowledge deficit and ask if there's anything that we can add to that. So I do try to bring it up every single time.
Yeah, it's actually really important. Our patients are Googling, they're on Instagram, they see stuff, they read stuff, and it gets confused. And, as much as they'll sit there and go, yeah, I know what we're doing, I think it's just so important to just be like, look, here's the boring 2-minute spiel again. I do need to tell you these things because it's the law, but it's also your face. It's you're the one who's going to suffer, if this happens. So let's just be clear what we're doing here. And then, you can move past that. But I just think it's really important to highlight. So your patient had some chin filler. What volume was put in and what technique was done?
So she ultrasounded it first and recorded the ultrasound so I could see where it was placed and what the screen looked like. And then she proceeded to go in the central chin to feminize her chin and make it more narrow. And she did everything the way I taught her. So, I couldn't pick anything out. She aspirated, she planted stabilized her hand, used a ring aspirator, and really did a beautiful job with technique, slow, even, steady pushes. She did everything right. It was Jupiter Volux. So the product was appropriate. The technique was appropriate. She just did everything right, except for the ultrasound exam. The ultrasound was read wrong. And the ultrasound in our office is new to everybody else. It's all very new to them. We had a trainer come and train when we first bought it, but she wasn't there that day. That day that the trainer came, she was at her other job. So she's one of those people that has a lot of gumption, but she has another job, right? So it's harder. That's another reason to hire somebody who's only dedicated to your office, because a lot of times trainings and events that not everybody can come to because there are other obligations. So anyway, she's the only one that didn't get trained on the ultrasound, how to read it, how to do it. It looked on the screen to her like that artery that she saw that was huge and pulsing, a big red stop sign. It looked to her like it was over here, but in reality, it was in the middle, right here. A huge hole. There was a huge hole in the bone in the middle with a big blood vessel coming right out of it in the middle. I sort of was armchair quarterback because I got the videos. I already knew that the tongue is going to be half necrosed, or half obliterated with the filler. So going back and looking at the video, I went, oh no, she read it wrong, because it's supposed to be straight up and down. She put it straight up and down, and she read it from left to right and thought it was to the left and right. It's hard to explain without showing you a visual.
I totally understand.
I'm sorry about that. So the orientation of the probe was confusing to her, because the screen always has the top of the probe to the left and the bottom of the probe to the right.
Yeah, and that's
so when her probe was up and down, it looked like it was over there to the left of her probe, right?
I was going to say, that's a quirk of ultrasound that I still sometimes have to sort of reset my brain as I'm looking at it, because you're right, it's a convention of what the screen shows you versus where your little marker on your probe is. And until you can sort of unscramble that, it's very difficult to understand. And for those listening, I don't know if we can do this, Julian. I don't know if we have your patient's consent, let alone your consent. Maybe we could use those videos on our Patreon to show people what we're talking about. So we can maybe discuss that.
Yeah, she gave full consent for education.
Okay, awesome.
So absolutely can.
Can you just explain what this quirk is? Because I don't know what you're talking about. Can you just explain for people that don't use ultrasound yet?
When you have an ultrasound probe, obviously you can hold it vertically or horizontally.
Yeah.
But either way, there's a marker on one side of the probe to tell you what the convention should be to put it on the face. So it should always, that little marker should either be on the left or facing up.
Right.
It should never be to the right or down. Otherwise, it's going to, on your screen, it's going to be the upside down, basically.
Right.
Or the wrong way around. So when you have that convention, when you put the probe on the face, when you look at the screen, you should always be able to orientate yourself, because you'll know where that marker is. But yeah, it's getting a bit it's tricky to explain. Essentially, it's just understanding what you're reading can be difficult.
Yeah. So I'm going to ask a curly question, just like your hair, Julie.
Awesome.
Do you think that because she didn't have that training and she used the ultrasound incorrectly and almost had a false sense of security because she was looking at something that she thought was accurate but in fact wasn't, that she did something that if she didn't have the benefit of an ultrasound there and was just doing a chin treatment as has normally been done before ultrasound came into the equation, that it almost put her in a disadvantaged position because she was using technology incorrectly that made her do something she would not have ordinarily done without an ultrasound?
Well, that's a fair question.
Yeah.
But I have to say unequivocally no.
Okay.
First of all, everybody who trains with me never has a false sense of bravado. I scare the crap out of everybody I train. No, absolutely not, because it's kind of like universal precautions. I teach them to always be careful, always be slow, always aspirate and do everything. Because you never know, right? So it's not like she just went in with needles blazing and just haphazardly throwing gel all over the place. No, she went slow. She aspirated. She took her time. She did everything right. So no, it would have, if she didn't have ultrasound, she would have done the exact same procedure.
Right.
The exact same, because she took every precaution. Knowing what I know now, I think her false negative aspiration was because the needle literally was in the foramen. It was blocked by the bone. And when I watched the video, normally there's a little tiny bubble when you aspirate in the hub of your needle. You'll see that bubble. And as she was looking, she saw negative aspirations, but there's one time when she's still there in the middle, right where that foramen was, one time where the bubble went straight up the edge of the syringe wall. You can see this line of air coming up the syringe wall rather than staying in the little hub. So I think that is the injection that did it. The patient didn't feel any pain. She just let her finish. But I think that's the one that did it. And she only put little aliquots of 0.1 to 0.2. So it wasn't a lot of product at all. Going back and critiquing like I said, armchair quarterback, she didn't have, I like a fresh needle after every single poke. The needle could have been changed more often, because I don't ever want to go in with a fish hook. I like it to be a fresh needle. After it touches the bone, it becomes a fish hook. So, but other than not changing the needle every time it touched the bone, I had no criticism at all. I wouldn't have done anything better myself. So I don't think that's true, but I think knowing how to use an ultrasound can be a huge advantage. I know that if she understood how to hold the probe and how to read it at that moment, she would not have put her needle in the middle of that chin.
Yeah.
She would have reached for a cannula or just said, hey, you're not a candidate. There's this variant of anatomy, and you have this variant of anatomy, which makes your chin unsafe for a median bolus.
Right. So she had unusual anatomy, so you wouldn't expect to find that landmark, that sort of vessel there.
Well, look, we have traditionally been taught there's nothing in the midline, go for gold, it's fine, do a massive bolus in the middle. And, just like...
I got a nice person to introduce you to if you think that's true. Right?
Yeah. I mean, look, but like with all of these things, if you scan enough faces, you'll see every variant. And so there aren't any real rules. I mean, there's a couple of, quite consistent things, but it's hard to have a rule in a face because we're also diverse, right? And genetically, ethnically, age-wise, and surgically, things change as well. So I just think it's good to have some principles of anatomy. And I know you're hot on anatomy, Julie, but, the ultrasound adds an extra layer. But of course, you want to be trained in that. But going back to your curly question, had she not have had the ultrasound, she still would have done the same thing, go down on the midline, aspirate, do small boluses and move her needle occasionally. So I don't think it changed the outcome.
Right. Okay.
It just maybe gave her false reassurance that there probably wouldn't be a problem.
And trust me, when I got back from Japan, we all got together at my training center and we had a weekend-long ultrasound course together. I'm like, hey, everybody needs to have hands-on. I want to see you do it. And they just picked it up so quickly and they got it brilliant. But I think it's one of those things, if you have a handheld ultrasound, take it home, check it out from your office and practice on your children, your husband, especially children, because they don't have filler in their faces, but it's just something you just have to do enough times. Like you said, it's like a video game. It's just hand-eye coordination. The little nubbin, as Danny Sher calls it, the nubbin is either from 12 o'clock to 9 o'clock. And just know these little things and play with it. So you don't have to think about it.
Well, how amazing that it was recorded as well. I mean, what a learning opportunity for all of us to sort of see it happen as it happened. I'm speaking with, in fact, Shafi Ahmed, who we had on the podcast many years ago. Shafi was my old consultant. He's a colorectal surgeon by training, but he's now also gone into sort of medical technology and virtual reality and augmented reality. And I've actually just hooked him up with Allergan to see if they have some synergy. But I imagine one day where we'll all wear a lens or just some glasses that record everything. So not only do we have a record of just what we're doing for legal purposes, but we can also stream that and teach thousands or millions of people. Why should we have 5 people crammed around a bed like, the old operating theatres where you're sort of, trying to look over the surgeon? It shouldn't be that way. It should be looking from the surgeon or the injector's point of view. So that's my goal, to try and make training and teaching, take it that way. And I think, that's just a small window of the opportunity of what it could do. So how was your injector feeling as all this happened? What was she saying? And in fact, why did they even look in the patient's mouth? It's not, it should be done, but many injectors don't do it. So when did they notice the tongue had gone half white?
So I'm really proud of her. She handled it so well and so immediately, but she got done with the chin. She put a whole mil in the area, 1 cc of Volux. And she was going to hand her the mirror, and she was like, "Hey, what do you think? How does it feel?" And she goes, "Oh, I love it." She goes, but my tongue feels numb. And she said, let me see, open your mouth. And then she saw that Harlequin tongue, and I said to her, "Hey, so when you saw that white tongue, did your underwear get brown?"
Touching cloth. Yeah, not good.
And she goes, "Yes."
More than touching cloth.
Yeah. It freaked me out. And I said, "So what did you do?" And she said, I calmly said, "Okay, so remember what we talked about with vascular adverse events? I think that's what's going on with you. I think we blocked some blood flow to your tongue. It's white. So I'm going to go get help. And I'll be right back." And she went out and she called the code, and everybody in our office stopped what they're doing and came in and helped and ran our protocol, which, by the way, I think we should all run drills in our office for both blindness and vascular compromise. So everybody knew what to do. Everybody just got right on it. I had nurses that were off that day that came in to help and assist her. So pretty much everybody at our office got hands on to help out. It was all hands on deck. And I clocked 15 hours on FaceTime in 3 days, from Japan, guiding them and helping them do our protocol. But they did it. I had nothing to do with it other than just being virtually there. But I'm really proud of my team. This is the first one they've ever managed on their own, and I couldn't be more proud.
Well, let's talk about that. So, what is your protocol? What happens? What's everyone's role? And how often do you do the rehearsals?
So the rehearsals, I'd like it to happen every quarter, but really realistically about 2 a year. But I think that acting it, because your staff might change, things like that. But everybody has a role, from the person who answers the phone to the practice manager. She's the person who's going to go scrounging for more hyaluronidase because there may not be enough, right? My protocol starts with prevention, but the real meat and potatoes is the diagnosis, to know it. And like you said earlier, that the little spidey senses you get as an experienced injector, knowing when something's not right. And so we talk a lot about, and I train a lot about diagnosis. And then getting that early treatment so they don't go home with this problem, and that they know when to call if they do go home with a problem, right? If it's a delayed response or an undetected response that you can't tell. So I think we don't talk about diagnosis or prevention enough. But she did it. She did all the key things for prevention, and she diagnosed it right on the table, which is great, and ran the protocol. It's getting the MA in there for pictures. You want to take a picture right away. She had help of somebody drawing up hyaluronidase and plain lidocaine. So the protocol in our practice is you take a cannula and 1 ml syringe and put plain lidocaine in the area. So that will vasodilate and make it easier for your hyaluronidase to get inside the lumen of the blood vessel. So while I was sleeping, they did all this on their own without my direction. They did all that. They tried to get in the lumen of where they were in the midline. They reported they got several flashes of red in the area. And they really thought it was the ascending submental. So they were coming in here and pushing it in. I know you can't see me on the podcast, but they are pushing it in the ascending submental most of all. I always say try the scene of the crime first, which would have been the midline foramen that we didn't know that it existed. But that's why ultrasound's great when you're running a vascular occlusion. You can see the quiet areas, you could see perhaps a foramen that shouldn't be there. But anyway, so they did all that. Every 20 minutes or so, you repeat. And in between, you're going to do heat packs, massage, Pronox to calm the patient down and maybe vasodilate a little more. It helps with anxiety too, because it's got to be scary for them, and it is. Let's see, what else am I missing? So repeat. And in the case of this tongue, before I woke up, somebody was out there doing research to look for a paper on tongue necrosis. They found one where it talked about injecting underneath the tongue at the floor of the mouth. So they put a little bit there. And then when they woke up, I said, let's do some strips into the tongue itself, post vertical strips of hyaluronidase into the tongue itself, and try to cannulate the facial artery because that might be connected in the submental area.
Well, I was going to say, there's tons to unpack there. There's so much. First of all, what was the patient saying? Because she sat there with half a white tongue, a bit numb. She's already been told this scary thing might happen, is probably happening. So I've seen the video. She looks remarkably calm and she's pretty compliant.
Thank you, Pronox.
Yeah. So I mean, joking aside, most clinics don't have nitric oxide in their clinics, but some do. Did you find it a valuable help? You felt like it kept her calmer?
Yeah. Oh, absolutely. But I got to say, before she got the Pronox, by all accounts, she was super cool. She was like, oh, yeah, do what you got to do. I trust you. She was really cool the whole time, honestly. And I think that you're not going to get that every time. But this patient is just a really, really mellow person.
Yeah.
I don't think she was very scared at all. But she probably, later when it kind of dawned on her, she was just like, oh, wait, I could lose half my tongue. Am I going to talk funny? How's this going to affect my eating, my swallowing? And I told her, hey, look, Dr. Kaplan is right next to me. He's here, and he talked to her too. And I said, he used to remove tumors out of tongues, and these patients do just fine. He's removed people of half of their tongue many times, and our goal is to not let that happen.
Yeah.
This is why we're going to put a lot of the enzyme into your lumen of your arteries and into your tongue and try to clear this in the next 3 days. And we have 3 days to make this right.
Yeah.
So just stick with us for 3 days. And that calmed her down a lot. And she told me later, hearing what my husband said and what I said about we have 3 days helped her sleep at night. And you got to remember, unless it's blindness and ocular issue, you have 3 days. It's better to start on day one, of course, but I think it's good for the patient to hear it's urgent and not emergent, unless, of course, it's vision.
Yeah, that's a good point.
And so what was happening? The patient was in your clinic all day for those 3 days and coming back in the morning, or like what was happening there?
Yeah. She'd come in whenever she could, probably like the afternoon, because by the time I woke up, it wasn't good. But if she came in the morning, I would just set my alarm clock on my phone to be 1 a.m.
Right.
So I'd wake up and go out into the living room, so I didn't wake up my son and my husband and be on FaceTime.
Yeah.
At 1 a.m. But I just followed her for longer than 3 days. I followed her the whole time I was in Japan. And when it got out of the urgency, like when I knew we got it and I knew that the danger was over, that was pretty much day 2. By day 3, she just had a little pain radiating along her jawline and in her ear. Her ear hurt, her jawline hurt. So interestingly, she was up in Southern Oregon doing hyperbaric oxygen because we ordered that for her. And one of my colleagues that works here in Southern Oregon met her at my studio and put another vial in her tongue, with Dr. Weiner's little strips technique. And she said that immediately cleared her ear pain and her jaw pain, just the little strips in her tongue. And so that was like the last blow for freedom. And that was day 3. So it took a village. Honestly, it took my team plus Kathy Love, a PA here in Ashland, Oregon. So shout out to her. And don't be embarrassed if you need help. People are going to be there for you. It's such a great community. But I'm so grateful to Kathy, and so is the patient. Yeah, because she just rid her pain just with one more vial in the tongue.
So did you visually see some sort of blood flow restore? Like, how were you seeing what was working? I mean, obviously the patient's letting you know that the pain's reducing and maybe the colour's changing in the tongue, but was there anything that you were looking at through the ultrasound to give you a definitive indication that things were resolving?
Yeah. First of all, the hyaluronidase in the United States is only 150 units per mil. You all have like 1,500, so 10 times more than we have. So when I say it, we use 55 vials, and that's what we ended up using on her, 55 vials. That's still not as much as the published cases.
Yeah, it's like 5 vials.
The published cases were way more. So with less than the published cases, we were able to reverse it, and I'm proud of that with my team. So visually, what I could see happen from the first time I woke up and started helping, the tongue was already looking less white and had pink kind of starting to show through a little bit. And each time we did a session of 3 vials or 450 international units, we would have her open her mouth and look at the color. And the color just kept getting more and more pink, less and less white and blue. So we were going by that. The patient had very little pain. It was mostly numbness at the time. For the first couple of days, the pain kind of settled in later for her. But visual changes, there's really not, it's hard to do capillary refill on the tongue, but we were trying. There was no skin changes at all. Her chin never got blanched, which is another sign that you got something occluded within, the blood vessel. And when it's distant like that, it's a blood vessel. It's not compression or anything like that. So it was pretty obvious to us that it was intralumen embolism.
I just did some math. So 55 vials of Hylenex is about 8,250 Hyalase. So 8, in fact, no, divided by 1,500. Yeah, 5.5 vials. So it's not a crazy amount for a significant occlusion, but I've got a theory. When I came to AMWC Miami this year, I did a very brief talk on facial dissolving and filler dissolving, and I'd sort of dangled the question. I didn't answer the question. I dangled the question to the audience that I'm not fully sure if Hylenex and Hyaluronidase are even the same thing. because they're made from a different product.
They're not. No.
And so when we sort of
one's an animal source, one's a human recombinant.
Yeah. Well, in fact, I thought that Hylenex was from ovarian hamster sort of recombinant DNA. That's what I read, because we don't use it here. So that's what I read.
Well, we have Vitrace and Hylenex. Those are the two that we have. Hylenex has a human source, and Vitrace is ovine sheep testicles, actually.
Yeah.
If you have a choice, we only have a choice of two that are commercially available here. So with the two, I choose Hylenex because it's less chance of anaphylaxis, because it's not doesn't have the sheep component or the animal component. And I believe yours is also sheep, isn't it?
Correct. Yeah, that's right. Well, most of the world, including Australia. But I mean, we're sitting here sort of trying to interchange and convert units, but I don't even know if that's true. Whether we can actually think of it that way, I don't know. Someone needs to do a study. Yeah, maybe when I come to the States, I'll bring some Hylays and we'll play with some gel in a Petri dish and see what happens. That'll be fun.
Sure. Yeah, compare. And you're going to win because it's, yours is stronger, 10 times stronger, apparently.
I don't know. I really don't know. I'm not sure.
I don't know if they measure it with different companies like the toxin companies do. I don't know. I don't know I don't know if we can compare.
You mentioned in your story that, sometimes you have to go out and scrounge for Hyalays from other clinics if you don't have enough. So what do you recommend that you have in stock, and what's reasonable? Because, you don't know until you have a disaster.
Like, I'm paranoid. We keep 50 on hand. Mm-hmm. That way, if you go through a lot of reversals that week, you at least have 30 there on reserve. But I try to have 50 as the round number to have. And we also loan out to anybody who needs it in our area. I feel like I just want to be that person to always do the right thing. So 50 is where I'm comfortable personally. 55 is the most I've used. One case I helped with here in Ashland, I used 52. And it was it took over her whole half of her face and her entire nose and her lips. And it was from a piriform aperture. And I used 52. I thought that was a lot, but when they don't have any necrosis or any bad things after all that happens, it makes you feel like, okay, that was worth it, to use all of those. And like you said, it's not that much in the big scheme of things. But yeah, I really think it can be hard in some communities to scrounge, to ask, because that's our practice manager's job, and she'll come back in and go, so Dr. So-and-so has 2. This other place has 3. So now we have 5. And that's 5. That's 4 more than we got the last time we needed help. Yeah. Last time we needed help, that first day we got 1 expired Vitrace, which, and of course, since I'm a nurse practitioner, I had to get on the phone, and I had to get my husband on the phone too, because he's the doctor. He wants to talk to the doctor first. And I know this guy, and I'm like, oh my God, are you kidding me? Yeah. Okay. Yeah. You can talk to my husband, the doctor. And then it was expired. So I'm like,
thanks, guy.
Oh yeah. So that's why I have 50. I can't rely on other people to come through. And just in case you don't know this, a lot of, oncology wards at the hospital use it as a dispersal agent for some of the medications for cancer. So that's one place you can go and ask if you know somebody who works in oncology in your local hospital. I don't, so I just. But anyway, we had enough. It was fine.
How much is a vial of Hylenex in the States? I'm just curious for you guys to buy.
A lot. It ranges really. How prices go up and down with supply and demand. Anywhere between $100 a vial to $150. Right. And so, if it was 150, how much did I spend?
Yeah, that's a lot.
Hyaluronidase. You got your calculator?
Yeah, that's.
I am not talented.
Yeah, that's a lot.
5,000 if it was 100, right? So 7,500 if it was. Hey, that's pretty good. 7,500 if it was 150. So I don't know. but it was worth it. Saved her tongue.
Yeah.
Right? She didn't lose her tongue. So I think it's a small price to pay. Also, the hyperbaric and the EO2 dressings, if you have a skin one, are worth it. Really, really worth it.
We've been trying to get in contact with those EO2 people to talk about their product, and they just don't answer my emails. So
they did it.
No.
Maybe they don't know you're legit.
Yeah, maybe not. You need to let them know, because it's an interesting product.
Those dodgy guys from Inside Aesthetics.
So basically, it's like it's a patch that you put on the skin that oxygenates the area, right? That's how it works. How successful do you find those things?
Well, we haven't. I'm gonna knock on a bookshelf or knock on a shoe shelf.
Yeah.
We haven't had to use them in our practice for our patients, because everybody who's come in, we were able to reverse it and not get necrosis. But if you have pending necrosis, they get to the pustule phase and it's starting to break down, I think, they'll overnight it to us, and they will deliver it. By the next day, you get it, at 9 a.m, and to get the patient in there and teach them how to put it on. Super easy. And the pump itself is the size of an iPhone Pro. So it's convenient. They could put it in a backpack or a fanny pack and just go about their business.
Right.
But we haven't had to use it for a vascular event yet, but we did recently have to use it for a medication error that damaged some of the skin. And that was really, really alarming for us, because I never thought this would happen. And I'm going to do a post on this soon. But I did have to call a couple weeks ago while I was in Dallas. I got a text from another one of my nurses who said that she accidentally grabbed sodium bicarb instead of lidocaine or xylocaine. Both of the labels are blue, and they're same size vials, and they're lookalikes. And we don't use bicarb generally, so it wasn't even on her radar, because it's not something that we usually. But for some reason that day, somebody put it next to the xylocaine, and so 1 ml got injected for a lower lip block on each side. And she showed me I know we're veering off of the tongue subject, but she showed me the pictures and said, "Is that bruising?" And I said, "No, that's not bruising. We need to go through our protocol with medication errors, and we need to, tell the patient, have her come back. We're going to, do all the things." So and then since that, I was in Dallas at Aesthetic Next. I asked the question to the big group, to an anesthesiologist, and 3 other people came up to me afterward and said they did the same thing. So that made me feel a little bit better. Their patients didn't suffer necrosis, just an injury, because it's too alkaline for the tissues to be happy. So I will say that EO2, the first day she put it on, it was so pretty and so brilliant. It was so much better. I'd say 50% lighter, because it was bright red patches where the bicarb went. And the third day, it was nearly gone. You couldn't even see it, and the pain reduced. So I do believe in these little patches. And I think as time goes on, they're going to get even better. And I think it's, for a lot of people, a lot more sensible to use these patches than to go into a tank at a center.
Yeah, if our listeners are wondering, we don't have these in Australia, but it's like a applicable patch that basically highly oxygenates that tissue that's suffering to try and salvage it or save it. And it seems to have some decent anecdotal results.
So getting back to the tongue patient, so day 3 comes around, you use the Weiner technique. I think that was the last thing that you said you did, and that seemed to almost clear all of the issues up. And so what happens from there? Like, what happened to the patient? How did you sort of resolve that or sort of finalize that situation? And then also with that nurse, like, what, as a business owner and as a mentor and teacher, what did you do then to sort of reconcile that with her, to kind of, obviously she's probably pretty traumatized by the whole situation, especially once the adrenaline has gone and the patient's fine, probably has a chance to then all that stress probably catches up with you and it can be quite overwhelming. So how do you sort of deal with those two things, the patient and then also your injector? Because I would assume her confidence will be knocked around as well, and there might be a bit of, you know, a bit of a mess to clean up there. So just walk us through that.
Yeah. I think anytime you have your first major event with your patient, or even a minor one, it feels major, you're going to be emotionally shaken up. And she was, but she also handled it really well on the surface. And the patient couldn't have been any more cool than she was. And the patient was very understanding, and she was so good about follow-up. So what we're doing what really helped the process is I said, hey, the patient is cool with us publishing this. And so let's write it up. Let's do a paper together so that we can get this out there for other people to learn. And the patient was so excited that something bad that happened to her might help prevent or help save somebody else's tongue. And also to publish, about this median perforating canal that is this little hole inside of some people's mandible. Get that out there too. So she was excited. The patient was excited to be published and to be written about and to be out there for education purposes. And it gave going over everything and writing it down in paper format and APA format, I think was really healing for the injector as well. Because she was able to go through every little thing step by step, watch the video again and say, what would I have done differently? And there really wasn't a lot she would have done differently. So, I think it was a really good process. Plus, it's kind of like ripping the Band-Aid off, because the next one she sees, she won't be so afraid. She's like, well, this isn't like a half a tongue or anything.
It's true. Yeah. And do you think it's changed her as an injector? Do you think that this sort of situation has changed the way that she approaches treatment, or what's been the upshot of this in terms of her career and the way she approaches patients now? Or is it still the same?
I think it gave her some stripes.
Yeah.
I think she feels more experienced now because she was able to get her hands on and reverse it without me being physically right there. It's kind of like the training wheels came off the bike. And I think she has more confidence now. She's really taken a deep dive into anatomy. She sort of did what I did when I had my injury on my face, right? You say, hey, do I want to learn more now, or do I want to go do something else? And I'm happy that she chose to learn more, learn from it, and not be embarrassed. She's going to publish this paper with me. She's going to write it up, and she doesn't care if her name's out there, the person who did it, because she's not ashamed. She didn't do anything wrong. It just happened. So I'm really proud of her with that. But I do think the first few, she said she's a little nervous on the first chin. She got back on the horse, right?
Yeah.
Of course, that's going to happen. But she did it, and now she's really good at ultrasound, and looking at chins with an ultrasound is like second nature. So, yeah, I think it's okay because you learn from it. And and again, it was so great to have a wonderful patient.
Yeah.
And same with the med air. The med air was a wonderful patient who's a nurse. And how do you handle it with the patients? You take care of them. You don't leave them. You do nice things for them. You really communicate with them very often. Maybe not every day, because you'll be a pain in the butt. But just don't let them be far from your mind.
Yeah.
And show them you care. And I think that's the biggest thing we could do, is show we care. And it's not just about, you're not reacting, you're proactive with their care. And I think that will set you apart from people that are just doing it for money, because that's not why we're doing it. The money's nice, to not be in the red, but we're doing it to help the patient. And I think they need to know that.
I think my first vascular occlusion was similar. It was either an ascending mental artery or a submental artery. You never know, because this was before ultrasound. But I learned from that not just, consenting and being upfront with your patient, but warning them almost immediately when the emergency protocol kicks in that this is going to be a few days, maybe even a week of back and forth. So they mentally prep for a fucked up week, to be completely honest, where they might need to explain to their husband, if they haven't already told him, that she's had some fillers, and they might need to check in with work. And, that thing with the girls might be cancelled, because if you sort of drip feed them information and are not completely upfront with what the next few days is going to look like, they get pissed off. They feel like you're withholding, and they sort of lose a bit of trust in you because it looks like you don't know what's going to happen. Whereas if you predict, okay, for the next 3 days, just like Julie said, we've got a window, but you're going to be back and forth, multiple injections, maybe some LED lights to clear up the bruising, and maybe some topical therapies, antibiotics, who knows? I think it's really important to be honest with people, because then they feel like, oh, okay, well, as crap as this is, this guy knows what he's doing. And that's the plan. I know what's going to happen now. So that's an important takeaway, I think. I've seen videos of the patient's tongue. It looked pretty full on for that couple of days. Are you able to do anything topically or to clean the tongue, or I don't know? It looked pretty, unsightly and pretty scary for the patient.
Oh man. Yeah. We put her on antibiotic therapy and oral steroids. And, of course she got thrush. So now she's got this fuzzy white tongue, and you would expect that, right? So we had, hypochlorous acid, mouthwashes, plus, my husband called in a thrush type of wash as well. I don't remember exactly which one. And so she did have some mouthwashes, just to get the flora out of there and to help with that. You could also probably do diflucan if you want, but yeah, that was kind of, pain. But I think the biggest problem she had was it was still kind of numb. And when she talked, she couldn't talk right, cause she was like tripping over her words. And when she's a business owner and a businesswoman, so it was hard for her to communicate with people she communicates with in her family. But they were all so supportive over her and her recovery. But yeah, not talking well is a tough one. And then of course the ear pain and the jaw pain was really kind of annoying.
Yeah. I think it's really admirable and invaluable that yourself and this nurse have embraced this complication so openly and have used it as an opportunity to improve your own internal practices and protocols, but also to share that with our community. And I think that, not just in this industry, but whenever you make a mistake in life, there always is the temptation to try and bury it, not talk about it, pretend it didn't happen. And that might be the easier way to go, but it's never going to make you grow. Like if you make a mistake or something happens, even if you didn't do anything wrong, something bad happened under your watch or by your hands, that if you don't embrace it and you don't use it as an opportunity to see what could have been done better, or how you can improve a protocol, or how you can help everyone else that's in that world, you're kind of missing an opportunity, I think. And it's kind of, and in some ways very selfish. And it can be difficult to do because you're putting yourself out there, because we live in a world where, unfortunately, a lot of people take pleasure in other people's misfortunes and mistakes, which is kind of sad. But I just wanted to say, I think that's, it's really admirable what you guys done and how you've been so open to share it and talk about it. I mean, this is going to be heard by, tens of thousands of people, and you've already got a big profile yourself. But I just wanted to say, I think that it's really admirable the way you guys dealt with it and how open you've been about it.
Oh, thank you. And I want to add to that is the patient literally said to us, I feel more confident going to you guys because you know how to handle these when they happen.
Yeah.
And even if I'm not there, like I wasn't this time, my team of, 8 beautiful, wonderful people, great injectors, they all pitched in and had this patient, they took really good care of her. And she said, I would never go anywhere else. So to give that gift of confidence in the team, it warms my heart. And for her to say, hey, I want this to be out there so other people, it doesn't happen to them. That's just really, really a great gift. But I don't think we should ever be embarrassed to talk about things that happen. And that's why I mentioned the dressings and the medication error, not to say, hey, we suck and there's complications happening out of our office. Well, guess what? There are complications happening out of everybody's office. You just have to be brave enough to say, hey, this happens sometimes. We're not robots. We are human beings. And this is an opportunity for people to look through them, for the medication error, look through your cupboard, see if there's any lookalikes, separate them, and have a meeting about it. You know how many calls I get about people saying, oh my God, I reached for the Hylenex for this lip VO and it was Dysport.
Yeah.
Because Dysport looks exactly like Hylenex.
Oh, really?
Green writing. Yes.
Yeah.
So many people put a whole vial of Dysport in the mouth area.
Oh my God.
And that's a long complication. And I probably have like 12 different injectors that have called me with this one.
Yeah.
So I always separate the Hylenex with the Dysport in our refrigerator, and I put Hylenex in a big box that says Hylenex so that it doesn't happen, right? But I never climbed to the fact that the bicarb and the xylocaine have the same vials.
Yeah.
Until this, right? And so now a patient's cool. She wants me to put it out there. Yeah, it's embarrassing. We've had two injuries in this year. But you know what? If we don't put it out, who's going to learn from it?
Yeah. These things happen all the time in general medicine. You hear about these things happening in hospital. Someone goes in for an amputation and the wrong leg got. That happened here like a while ago. Someone got the wrong leg cut off.
Oh, it's horrible.
But these things happen in medicine. It's just because we're in cosmetics, it gets so much attention and it gets so much scrutiny. It's kind of a little bit unfair in some respects because people just feel like they're just being targeted and you just got a constant, you're in the crosshairs of either the media or a regulator or your colleagues who are going to jump on you. And it's like, yes, if you're being silly, you're not taking proper protocols, you're acting in a way that's not not correct and fair enough. But I mean, mistakes happen. As you said, we are human beings. And I do feel that we do get a lot of unfair scrutiny because of the industry.
Yeah. I mean, because there are a lot of independent solo injectors around the world and, maybe less eyes on what's going on behind the scenes, maybe less compliance, maybe they're not checking their cupboard for expired stock and, all this kind of stuff, then I think that criticism is fair. Yeah. Whereas I'm sure Julie's running a pretty strict ship. And sometimes these things just happen. It's human nature, right?
Well, if you've got 8 injectors, are they all on every day together at the same time?
No. Usually there's between 3 and 4 per day.
3. So you'd be doing what? At least 30 to 40 treatments per day. So like 200 or 300 procedures per 200 to 300
That's
procedures
per
week.
A lot of stock.
That's you can be the most careful driver in the world.
Look at it like that. That's pretty good odds, right? That we only had 2 last year or this year.
Yeah, 100%.
But so far, I mean, the year's not over. But yeah, I think they're doing a great job. Before this tongue case, I'm the only injector in the entire office that had a vascular occlusion accident. No, that's not true. Another person had a chin issue too, but we resolved it. It was fine. It wasn't the tongue. It was a little less scary. But yeah, before the other chin, I was the only one. And I thought, why is it always me? Like, and my needle was always moving and it was always tiny amounts. And I've never had one with an aliquot or bolus anywhere. It's always with my needle moving and always tiny amounts. So I thought, and then one of my nurse teammates said, Julie, I think it's because you're diagnosing them. You're seeing it like people don't maybe always see it and it just resolves on its own. And I think she's right. I think people go home with vascular occlusions. The patient assumes it's a bruise, but there's collateral circulation, so it never gets picked up. And so I always say, like, when somebody says, oh, I've never had a vascular occlusion, I say right after, that you know of. Yeah. That you know of. Because how many do you think that we've had that we don't know about? I think it's a lot. How much filler is put in veins? I think it's a lot. We get away with the veins for the most part. unless it's in an area of swelling, But yeah, I think I see it all the time when I'm scanning faces now. I'll see somebody had cheek of filler, and I could see this vein of Restylane lift going up her temple. And she goes, "What's this rope here?" It was filler going up in a vein, just going up, and she goes, "It's been a year. It's just sitting here. It's been a year." So it's on the Patreon. I reversed it, and then, it cleared, and the tension in her head went away, no more headaches. And then she got a black eye, interestingly, from my poke to clear that.
Yeah.
But that's a vein.
Yeah.
So I think we just don't diagnose them.
Yeah, that's interesting. What do you think? Do you reckon there's a lot of undiagnosed stuff, Joe?
100%. I mean, we referenced in our last podcast with Julie, Professor Sebastian Cotofana did a post, yesterday when we were recording this, and lots of heated debate about, occlusions and aspiration and moving needles and stuff. And I think you said yourself just now, Julie, your 5 VOs have all been from moving your needle, whereas, some of the, biggest personalities here in Australia have been advocating for the moving needle technique versus a static needle when aspirating. And to be honest, I think you can criticize either.
Go ahead.
But I agree. And in fact, I left a comment on that post and I referenced you, Julie, because I think that we probably do have subclinical VOs all the time. If you bruise someone, by definition, you've gone into a vessel and caused a leakage of blood. So you were in the vessel at some point. And how do you know how much filler went into that vessel at the same time as you made it bleed? We don't know. But most of these things don't turn out to be an ulcer or an evolving vascular occlusion. But probably that we get subclinical VOs all the time. We just don't know it.
So blissfully unaware.
Yeah, I agree.
Yeah, well, I don't know if we're unaware. It's more just the probability of it evolving to something bad is rare. So we accept that risk.
Yeah.
Otherwise, we'd see a lot of suffering people, and we don't. It's just not the reality.
Now, I think patient history really matters. So, I mean, is your patient a smoker? I think they're more likely to have that choke phenomenon that I saw. And, if I'm doing retrograde threads in the subdermal layer, you wouldn't expect all the VOs to happen, but those are what happened to 5 of my patients. They were all subdermal threads. 1 was with a cannula and 4 were with a needle. 2 of them were Sculptra in the cheek. And it really, we just need to know that they can happen. Tiny bits can irritate the vessels, cause them to choke, or tiny bits can cause trouble some way or another. So we shouldn't have that, like you said earlier, false sense of security ever when we're injecting. We need to keep our eyes open for the signs of it.
Yeah. We sort of touched on what vessel you think was affected, but we didn't really go into the anatomy of how the tongue is related to the external circulation. So you're going to write a paper on it, but just explain to the listeners who are a bit confused, what do you think's happened? And then how did you go, you call it fishing for red, when you're looking for the facial artery? How did you go about treating it?
So at the time, when I got home and evaluated the ultrasound in person, not just a video that was emailed to me, I could see that there was definitely a foramen. And on ultrasound, the foramen looks like this little trap door that switches down. And you could see the artery coming from below and coming up, right? So when I came back, I was like, there's a foramen there. And you can see it clear as day on the videos that I posted. So that foramen, Dr. Leslie Gersman replied and said, that looks like a median perforating canal. And I was like, I've heard of a median perforating canal, but nobody talks about this. And I did a little research and I was like, oh my gosh, she's right. That's what this is. And then I dived in a little bit further, and apparently they're rare, but since this chin injury, I have scanned almost everybody's chin. I've seen it 5 more times, 5 more people. I've seen this hole in the middle of their chin. So I know that you can't, probably see on the pod, but anyway, right there in the middle. So I'm veering off what you asked. What did you ask me again?
Well, I mean, I guess my question is, we don't normally have that connection, or maybe we do and we just don't know it. But normally,
so the median perforating canal is a direct, many times direct into the sublingual artery.
Right.
So that sublingual artery can come out and come through the hole in your chin and to the other side. So that's what this patient had. I'm concerned. I'm totally convinced of that.
Yeah.
Interestingly, after she healed, she came in. I scanned her again, and you could see the foramen there, but there is no longer a artery going through that foramen.
Yeah. Okay.
So that artery is gone. It never returned. It's toast.
Interesting. But I guess that's proof that normally the tongue is supplied by a branch from the external carotid. It normally just comes off its own artery. It's not normally connected, through the chin. So it just proves how variable these things are, and
and some papers said that it can also, the lingual sublingual can be tied to the facial artery as well, and these submental artery. That's why our rationale for trying to get into all of those arteries in the lumen, I think, was sound, and it worked. So we got into the facial artery. We put pressure here so that it would go backward.
Yeah.
So got into the facial artery here, and with ultrasound guidance, so we could see it as not the vein, because it goes vein and then artery. So got into the artery, and then we, put pressure above it so it would go down. Then they got into the ascending submentals as well. They tried to get into the center. I don't think they did, because that artery is not there anymore. And then they did, like I said, a little bit on the floor of the mouth, and a couple of vials into the tongue itself. And that cleared it, and the facial artery. So my technique is basically flood with lidocaine, so it's comfortable and it vasodilates with a cannula, then go on with a needle after a few minutes and start fishing for red. So you do negative pressure on the plunger. So having an aspirator tool helps you. Mm-hmm. And once your needle bevel goes underneath the skin, you go into the area you think that artery is, and until you get a red flash, and then you push the hyaluronidase immediately, so before you move again. So you stay in there and try to clear it.
So to be clear, you think you were able to cannulate the facial artery with a needle using the fishing for red? That's really interesting. I mean, I've never done it, but I had this chat just a week ago. I was in Singapore at a cadaver course, and the plastic surgeon was teaching us, and we were talking about occlusions and blindness, and they were asking us, what strategies might you come up with? And I told him exactly that, because I'd learned from you. And he said, no, it's not possible. The facial artery is too tortuous, and if you touch it, it will spasm. And I said, I'm telling you now, it's been done. It worked. Jubilant Julie did this, and it will be published. So it's really good that we get that information out there, because some people were teaching it's not possible.
I don't know how people can.
Oh my God, it's so possible.
Yeah.
It's in any of the arteries, if you can get into an artery with filler, you can get into an artery with a reversal.
Right. Exactly.
It doesn't make any sense.
And you're almost using the principle of what we're trying to do when we're avoiding obstructing an artery, but this time you're using the same principle to get in it, but you're just...
Yeah, just like starting an IV, where, we know how to do that.
Yeah.
It's just, it is counterintuitive a little bit, but it's so logical, right? If you have an embolism, you have an obstruction, really blocking blood flow to an area, why not go directly into it? We know carpet bombing works a little bit, probably because it vasodilates a little bit. We don't really know how much crosses a live membrane. The De Lorenzi studies were done with cadavers, which, things change when you die. They're a lot stronger when you're alive. So,
valid point.
Yeah.
All we used to do. And about 3 years ago, when we had that one I told you about with half of her face was blue and mottled, her whole nose was purple. That's when it occurred to me, let's try to get in that facial artery.
Yeah.
And it worked. And I'm telling you, sometimes a butterfly, you could just stick a butterfly in there, tape it to the skin, and all you got to do is just keep putting it into the tubing, and just watching it. But we saw the nose go from purple to pink after we got into that artery. So it is a little challenging to get into there. It's not easy, and it's maybe uncomfortable for the patient a little bit, but you can do it. I taught that to Steve Yolen, and he's been teaching it to people too. And he's seen, dozens of people, I think, that he's helped clear the problem. I have helped a lot of people, and it just works. Yeah. If you don't have an ultrasound, it's a way to find that artery without guidance, without seeing it. Because just when you see that hub turn red, you're in. Of course, you could be in a vein, might not do anything, but you just keep trying.
Yeah, knock on wood. Haven't had a blindness case yet, and I hope I never will. But if it ever happened, I think I would do that. I would try to find the facial artery. I would make up probably 3,000 units of very concentrated Hyalase and just do a push, just to try and get some Hyalase, up into that circulation around the eye. And of course, you can aim for supratrochlear, supraorbital as well.
Supratrochlear, yeah. That's our first line of therapy for blindness on our protocol is what Mike Clegg did. Another Aussie.
Yes.
He just went into the supraorbital area and just flooded hyaluronidase. And guess what? It worked. Yeah. So he's the only person I know that's ever, at least got partial vision back. But I think it's brilliant. So retrobulbar, I don't think there's any proven cases, right? There's nothing, there's zero. People do it, but if I'm going to stick a cannula underneath the, behind the eyeball, that's really not in my scope of practice. But trying to reverse inside of a vessel, I believe is. So our protocol is try to do what Mike Clegg did and try to cannulate the supratrochlear, supraorbital arteries.
Yeah,
and there's research too showing that if putting it, under the orbit around it here, but you could get bruising, you could, have a hematoma, that would be a drag, but I think it's perfectly, it makes a lot of sense to try to get into that. The shortest distance to the back of the eye would be that supraorbital, supratrochlear.
100%.
But why not try the facial artery too? It's pretty easy to get in.
Yeah.
Try it all. Wow. Do what we did with the tongue, we're just hitting all of them. We were hitting submental, mental, we were hitting facial, the tongue itself, the floor of the tongue. We just put it everywhere and it worked.
Yeah. Just to finish off, maybe just some sort of general things about vascular occlusions. We sort of came up in our last podcast, but let's just sort of go over it again. It's more relevant now. Do you think it's obviously we've already said it probably is an occlusion of a vessel, but do you believe it can be an external compression, a spasm, all of the above? What's your take on it?
Yeah, I think all of the above. I think especially nasal tip very often can be compressed. Not always, of course, but I think there's some areas that are more prone to compression. I think a periorbital, veins, even just compressing on a vein can cause severe malar edema. I think compression is something to consider, and spasm, absolutely. I think it's just, we're just still learning about it, but it's the only thing that explains tiny amounts causing calamity.
Yeah.
Just a tiny little bit in the lumen would cause, and it makes sense, right? Because it's your body's way of protecting your brain from a stroke. It's going to shut down if something's in the vessel wall. Yeah. It's going to go like, don't come in here. And if you happen to be a smoker with very poor circulation already, you got double trouble. I think that's a big thing. And sometimes maybe it's a combination of both. You have spasm plus you have an embolism. Yeah.
We've got obviously lots of listeners who are maybe earlier in their career, and this stuff terrifies them. They hope they never get an occlusion, and sadly, the more you do, the more likely it is to happen. So what advice would you give to, those newer injectors who've not seen one? What equipment should they have in their clinic? We've already discussed how much Hylenex or Hyaluronidase you might want to have. And, what protocol should they be following? Is it the De Lorenzi? Is it, the one that they're prescribing doctor tells them, because you ask 100 injectors and you get 99 answers as to what to do.
And you probably get 300 answers.
Yeah, exactly. You probably get more. So what's the sort of the survival kit for your first VO? What should people have in their clinic?
Yvonne Delos has a aesthetic ER. She has a course and a kit that comes with the course. I tell them to just go online and take her course and get the kit. It's the best money a new injector could ever spend. I have one in each clinic. I love it. She thought of everything. And she even has a little occlusion protocol in there. So it's one of those things that you have to be prepared and run the drills in your office just so you can know it by heart. You're not going to sit there and read a 2-page protocol when you're in crisis and your patient's in crisis. You really need to know your stuff. And I think the only way to do that is education. Maybe watch some, subscribe to some Patreon people that are all about safety, and just educate yourself as much as you can and your team. If your medical director does not know, HA from Sculptra, then you don't have the right medical director, period. I don't care if they're $100 a month and that's who you could get. They're cheap. Get somebody that knows their stuff, because when the chips are down and you're an RN, you can't diagnose or treat, and they don't know what the heck they're doing. You're screwed.
Such a good point.
They'll get sued. You'll get sued. Nobody's going to be happy, especially the patient. So have a knowledgeable team all around you. And I can't say that enough. And just have, protocols change. So don't be static. Don't say, hey, I bought Yvonne Delos' kit. Here's a protocol. I'm good for another 10 years. No, because every year we're learning more stuff. I mean, we just learned about choke. We just learned about variant anatomy. So nobody seems to know that there's 0 to 5 zygomaticofacial foramens, by the way. So we're learning every year. We're learning more and more and more. So don't be static in this. Don't be complacent. Don't say, hey, we got a protocol, we're good. No, keep researching, keep learning. So I say that to new and old people like me. So never stop learning.
100%. That was great advice.
Lots to fascinating.
Yeah.
Fascinating.
I've got one more, I guess, sort of logistical question, and maybe this didn't happen with your patient, but let's say they were angry or a little bit fractious in that sort of dissolving process where things sort of get a little bit more heated. Where do you stand with things like refunds or apologies or, I don't know, transfer of care to someone else?
The money thing. I'm so glad you asked, because a lot of people don't do what we do. And I wish everybody did. First of all, apologize right away, because nobody expects to go in. You expect to go in and get a nice, pretty outcome and walk out feeling better, looking better. And all of a sudden, you've got a horrible thing happening that's going to affect the rest of the week, at the very least, right? So we need to apologize. We need to take responsibility, and we need to hug them and say, I'm so sorry, but I got this. I'm going to help you. I'm going to get you through this. We're going to get to know each other really well. It's going to be a few days, maybe even longer, but I got you. I'm not letting you go. And we got this. Our team has you. Be that way. Don't be just like, oh, you're fine. And then underneath you going, oh shit. You gotta be real and be compassionate and care. And then don't send them to the desk to pay for it. That's insane. I can't imagine saying to our tongue patient, okay, so that's $900 for that syringe of Velux, please. What? No, I bought that Velux. I don't want her paying $900. So no, don't let them pay for anything. In fact, I will reimburse them if they have to see the dentist, if they have to see a dermatologist, if they have to see a wound care specialist. I'm like, please save your bills and send them to me. I'm going to be reimbursing you for any out-of-pocket expenses that has to do with what happened. I got you. And I don't mean I got you just emotionally. We got you. Our team has you, and you're not going to pay a penny. I wish we all did that. Hyperbaric oxygen, all the Hyaluronics, you're not going to charge them for that. So like I said, if you treat them well, they are your patient for life, because they won't trust anybody else. And that's the way it should be. But if they're angry, hey, you know what? That's the stage of grief and it's normal. I don't know why our tongue patient didn't really get there. I think it's because she felt so loved and cared for. But if she did get there, I would say, you know what? I get it. This is a stage of grief. I went through it too with my injury. You know, first denial, I did that. And then anger. I wanted to sue the makers of Radius. I was so angry. That's normal. I'm glad I didn't. But, you know, I just decided to focus on healing. But people get angry. That's normal. It's absolutely, you know, yeah, it's weird if they don't really. Medication error, same thing. You know, they're going to be angry right off the bat because, like, what the heck? Didn't you do the 5 checks? Didn't you? What the heck? You just got to admit it right away and fix it. Don't charge them.
I agree with everything that you said. However, I will add to that, just from a business person's perspective and someone that's owned clinics and had multiple letters from lawyers and claims for things that staff of mine have done over the years. And I would say yes to everything that you've said. And just like you have a protocol for medical emergencies, you need to have a protocol in place from a business perspective. And that would mean having an understanding from your insurer how they would like you to handle this kind of situation before it comes up. Because at the end of the day, I'm not sure how it works in the United States, but they're the ones that go in, and if someone tries to come after you legally, they're the ones that are going to defend you. They're going to come up with their own legal strategy. So you want to be fully aware of how your insurance company and you are going to work together to resolve this, so that they're not going to try and say, well, you did this, therefore we're no longer going to cover your policy, which can happen. And number 2, you need to have a relationship with a lawyer. This is just part of your support team. So you have a prescribing doctor, you have an insurance company, you have a lawyer, you have an accountant. These are all the people that are going to support the back end of your business. So when the shit hits the fan and you have a complication like this, as Julie said, having all these protocols planned out, know exactly what your team's going to do and practice them, rehearse them. You need to understand from a business perspective how you're going to handle this, because certain things that you say and do at the time, putting omissions in writing, saying, and every situation is going to be different, but you need to have advice from a lawyer and your insurer so that when this situation happens, you know exactly what to do, so that you can do what you said from a medical perspective, but you're also not putting yourself in a position where someone's going to effectively not cover your policy or sue the pants off you because something you did was just a mistake in the heat of the moment and everyone's panicking. So that would be my only piece of advice, is to do your due diligence from both a medical and a business / medico-legal perspective.
And document the crap out of what everyone said, what you did, photos, videos. Julie's done it all. But, because things get missed or mistranslated, and it's just good to have that timely notes, which I know injectors are pretty poor at. They tend to leave it till the end of the day, and they're trying to, I don't know how they do it. I have to do it between each patient.
Well, contemporaneous notes. I mean, we've had lawyers on here before that specialize in suing doctors and nurses, and they've given us some pretty interesting information around, if you get something wrong on your notes, like if you get the age of a patient wrong, if a lawyer's looking for a way to get money out of you and they find something in your notes that doesn't add up, they'll exploit that. And the example was that if you can't even remember the name of the age of your patient, how do we know anything else written is correct? And so that's, especially living in the United States, right? You guys are the most litigious country in the world, and closely followed by Australia. So, it is, unfortunately, you've got to try and balance taking care of the patient, but also making sure you're dotting your I's, crossing your T's, and you're actually prepared for this situation from a 360-degree perspective.
Definitely.
Well, did you have anything to add to that, Julie? Sorry.
I think it's even worse in some states than others. In California, we had private investigators coming into offices asking for Latisse and arresting nurses who sold the Latisse. It's pretty ridiculous. Of course it's a prescription and it needs to have a prescription, but it's bad. Or a nurse just saying a dose of toxins, like, okay, so we're going to draw 45 units. Okay, well, now you're a nurse who just prescribed, so you're under arrest. That kind of stuff is happening in some states and not in others. In other states, It's totally Wild West. So I happen to have a business in California, which is a really tough state. So you have to know the laws. You have to have, like you said, have an attorney, have a team, and be in really good contact with your insurer. And make sure everything is as it should be, your policies and procedures, an OSHA visit. I think it'd be great to hire an OSHA person to be an injector so that they can really look at everything with a fine tooth comb too, because it's scary. I don't want to be caught with our pants down. It's a lot to think about having a business.
Yeah.
All these things are important.
Yeah.
And you have to wear those legal hats too, sadly.
Of course, yeah.
Because that's the way the world is.
Yeah.
So OSHA, is that the health authority? Who are they?
Yeah.
Right.
Yeah. The occupational health and safety.
I thought you were saying, oh shit.
But yeah. I never thought about that. Oh my God, I love it. Oh shit is here. Oh no.
Oh shit authority.
Oh, that's bad. Oh yeah, but that's what that's exactly what I would say. Ugh.
Wow.
But yeah, you got to be careful.
Yeah, you do.
Well, Julie, we have really appreciated your time. It was a fascinating story and a rare one that we can all learn from. So again, if we can have the consent to maybe show some of the anatomy and maybe even the videos to patrons, that would be such good education for everyone.
Yeah, and speaking of education, when this podcast comes out, we'll obviously detail how people can subscribe to your Patreon and start learning and being part of your community. So happy to support you there. And so much to learn. And I think, as you said, we don't know what we don't know, right? And so we're just really at the beginning.
Which is a lot.
Yeah, so that's why these conversations are so important. And
yeah, none of us know everything. And if we do, then we probably need to go see a therapist because we have narcissistic personality disorder and we probably need help.
If you're the smartest person in the room, it's time to change rooms.
Yeah. Thank you so much. And look for me on your Patreon too.
Thanks, Julie.
Can't wait to have you. See you soon. Take care. Bye-bye. For our latest news, follow us on Instagram at Inside Aesthetics Podcast. If you want to get in touch with myself or David, follow us on Instagram as well at Dr. Jake Sloan and David_Inside Aesthetics.
Join our IA Patreon platform for invaluable business and injectable education. Get access to our global community of like-minded professionals, live and interactive Zoom sessions, hints and tip videos, webinars, and more. Head over to www.insideaesthetics.com/Patreon for more information.